is an Omaha native. He grew up right here and spent 5 years of study at Creighton University, and we are so proud to have him back amongst us today. As an undergraduate, he studied philosophy before moving on to medical school at the University of Texas Southwestern. After training in internal medicine at the University of Rochester, Dr. Luby spent time living abroad in both Pakistan and Bangladesh, where he wore just a few different hats. Today, Dr. Luby is a professor of medicine at Stanford and the director of research for Stanford Center for Innovation in Global Health. He is probably best known for his work in demonstrating the importance of hand washing on disease reduction in low-income countries, for characterizing the epidemiology of Nipah virus transmission in Bangladesh, and for explicating the importance of unsafe injections for transmission of hepatitis C in low-income countries. Some of these projects inspired his current research focus on practical solutions to environmental problems that directly impact human health in low-income countries, with his focus still being in Bangladesh. Some of these problems include water sanitation and hygiene, the adverse effects of brick manufacturing, and prevention and characterization of zoonotic disease transmission. It is these incredible initiatives that have brought Dr. Luby around the globe and into second place at Dr. Anthony's passport stamp competition last evening. Yet another challenge that Dr. Luby works to address, and the one we'll all be learning about today, is the profound impact of lead exposure and intoxication in rural Bangladesh. So if you would all please join me in welcoming Dr. Luby.
Thank you very much, Aaron, and thanks to all the organizers, to this incredible group of young, energetic Creighton medical students who have done so much to bring us together as a community to talk about these issues. I'm a physician. I'm a physician trained in internal medicine who did additional training in epidemiology and focused largely on communicable disease, but not exclusively on communicable disease. And my work in global health has been research. So there are lots of ways that physicians can make contributions in global health, and not only physicians, but people generally. There are all kinds of ways to make contributions to these big problems. But I'm somebody who has spent full time for the last 25 years doing research. And the reason I focused on research is because I think that some of the big problems we face, they're really big and we don't know how to solve them. And if we can figure out, if we can generate some new knowledge, we can use that knowledge to make change. Sometimes a little change, and sometimes even big, radical change. But the process of generating knowledge in itself, if it's strategic and if it's focused, can be useful. I can also say it can be really fun. It can be really fun and engaging. I learn things and are exposed to people and situations and ideas that I never would have imagined, despite a broad and good education here. 5 years as an undergraduate at Creighton. So, although some people are research, oh, you guys are just publishing, you kind of pointy-headed nerds and not really, in the center of the problem. I want to tell you, it is a great thing to do, and it is really exciting to do it for global health. But it's hard. It is really hard to do meaningful global health research. And one of the big reasons it's so hard is because the problems we're facing are hard. If these were easy issues to take care of, our predecessors would have done it. They've taken care of it, so we're left facing really hard problems. In addition, if you're in the knowledge creation business, what knowledge are we going to create? Then we also need to think about, well, what are the things that we already know? And so how are we going to figure out what is known and create new knowledge that's useful? And that turns out to be pretty hard as well, because there are 1.7 million new scientific publications each year. So I don't want to make the medical students too nervous, but there have already been several hundred more published since we started this symposium last night. So there is a lot being published all of the time. And you've got to decide, what are you going to read? This is both, what are the abstracts you're going to look at? What's kind of the things you need to know about in general? What are the between, say, 50 and 500 articles that you're really going to read in depth? That you're going to read every line, that you're going to make highlights in, that you're going to put side notes on, well, this might be an opportunity for me to work on in the future, or boy, I better check these other references too. So which of those are you going to really read in depth? And how, out of all of this morass of tens of millions of articles, are you going to tell a story? Are you going to figure out what is important knowledge and what isn't? So basically, the strategy of mastery, which is probably how you have to get through pharmacology, just make the flashcards, put it in. Mastery will work for that, but it's not going to work for figuring out how do we generate new knowledge. For that, it's really an exercise in creativity, in being able to tell a story and being able to put a story together, and in being very strategic and efficient with your time and with resources. So why work on lead? Well, part of that is part of this whole strategy to begin with. As we started to work a little bit on lead, people say, oh yeah, and we've got a problem with cadmium too. And people get really excited about cadmium. I'm sorry, I'm just not working on cadmium. Why not? Because I'm trained as a physician, and lead really matters. Okay, I know cadmium causes some renal insufficiency, but it's not like lead. Lead results in marked, irreversible impairment of intellectual function. There is no safe level. If mothers are exposed to it, their children have brain damage, irreversible brain damage. If adults are exposed, there's cardiovascular disease, immunological disease, endocrine disease, neuropsychiatric disease. Lead is a bad actor. And so part of how I think about global health research is work on problems that matter. Lead matters. So if we look at the N. Haynes study, which is nationally representative of the US, and these are good data. Now, this is US data, but so this is not Bangladesh, but they looked from 1988 to 1994 and identified that for each 10 micrograms per deciliter increase in blood lead level, these children were 1.57 centimeters shorter, and their head circumference was a ½ centimeter smaller. So just the exposure to lead, even after you control for other confounding characteristics, made children grow less, and their brain and head grow less as well. And really, although these are the best measurements of this N. Haynes study, wherever this has been looked at, and even in animal studies, this is a very consistent finding. Lead impairs growth and impairs the size of the brain. There have also been careful studies looking at the intellectual impacts of lead. So Bruce Lampier collected data from 7 different international population-based cohort studies, studying over 1,300 children. He got the original data, following them from birth, and whose intelligence was then measured later in life. And looking at this graphically, what you can see along the x-axis is as lead concentration increased, IQ decreased. Lead makes us stupid. But even another striking characteristic of this relationship is what we call a supralinear relationship. That is, at very low levels of lead, there's actually a bigger impact per change in lead level on intelligence. So if you look at that, moving from 2.4 micrograms per deciliter of lead to 10, children lose approximately 4 IQ points. From 10 to 20, another 2 IQ points, and from 20 to 30, yet another IQ point. So one of the things, we've been a little accustomed to thinking about blood lead levels that are much higher because we remember the US experience with having lead in our gasoline. But this tells us even at very low lead levels, there's profound impact on the intellectual development of these children. So where does lead come from? Lead primarily, it's a geological element, and so it gets into society because of industrial processes. So leaded gasoline has been the biggest cause of lead intoxication to humanity, but that was banned in Bangladesh in 1999, earlier in the US and other places. Another prominent source of lead is in paint. Battery recycling. How many of you drove a car today to get here? Okay, so that was started with a lead acid battery. That battery will be recycled, and there'll be risks of lead entering the environment because of that. And also solder. There's a lot of lead historically has been used in solders. So from 2004 to 2012, I worked at the International Center for Diarrheal Disease Research in Bangladesh. And the mission of ICDDRB is we will help solve significant health challenges facing the people of Bangladesh and beyond, especially the most vulnerable, through the generation of knowledge and its translation into policy and practice. So ICDDRB is an international health research agency. They're trying to generate knowledge, and they're based in a low-income country where the problems are. So you can see, for me, with my interests, this is a great place to work. So one of the things they did at ICDDRB is every week they sent out a weekly summary, and that included a list of any peer-reviewed publications that had been published in the last week. And at that point, they were publishing about 150 publications a year, so 2 or 3 a week is what we'd usually see. And one week, I noticed a study that surprised me was mentioned, and then I read the abstract and read it in greater detail, because I'd done a little bit of work on lead in Pakistan earlier. And what they found was in this district, they're marked in red, that's Chandpur district, which I know the district. It is a rural district. I mean, there is nothing there but rice fields. And they collected urine from children there, and they had a mean of 0.6 micrograms per deciliter of lead in urine. Now, you can get all academic and say, wait a minute, urine's not a good analyte for lead, so, are we really going to believe this? It's not the perfect analyte. Concede it, but why are kids in rural Bangladesh, where there is nothing but rice fields, have lead? I thought, that's peculiar. It was peculiar enough that maybe I ought to be looking in those tens of millions of research publications and see if we can learn anything else. And turned out there had been an earlier study in rural Dinajpur. So you can see a very different part of the country. And again, these are unselected kids, so these are not kids who had any symptoms that would make people think that they might have lead intoxication. 183 school-age children, 14% of these kids had lead greater than 10 micrograms per deciliter. That's at a level that's physiologically clearly meaningful, but also really puzzling. Why? Mitra and colleagues also collected blood from 16 parents, and a quarter of them had high blood lead levels. And he looked around and he said, I don't see any obvious exposure to lead. The only industries are brick kilns. They bake bricks, they dye fabric, and some weaving. So not sure why this is going on. One other piece of relevant literature came out of the University of Chittagong, where Professor Muhibullah collected agricultural soil. And so what he did basically is people live in compounds, and so he collected soil from right out in front of the home, and then he also collected soil from out in the agricultural fields. And he compared the lead concentration in those two. And what he found was that lead was twice as high in agricultural soil as compared to non-agricultural soil. And actually, these lead levels aren't that high, but it still was strikingly different in agricultural versus domestic soil. And so it made us think, I wonder if there's something that they're putting on the agricultural soil, they're putting on their crops that might be increasing lead. So again, further looking in the literature, there is a pesticide, lead arsenate, that was widely used in apple orchards in the US from 1890 to 1940. And you look at those lead levels, they are really high. Banned in the US in 1988. And we had known from other work we had done in Bangladesh that pesticide use was very heavy and irrational. We had seen, we had gone to outbreak investigations and really had seen a lot of diverse pesticide use. And indeed, looking in the literature, 47% of farmers were overusing pesticides beyond what the Food and Agricultural Organization was recommending. And basically, 70% of farmers reported applying pesticides within 3 days of harvest, which means then if you're eating it, the product is still going to have pesticide on it. So we had a hypothesis. Our hypothesis was that residents of rural Bangladesh have elevated blood lead levels because of exposures to pesticides that are labeled as one compound, as another compound, but actually contain lead arsenate. Lead arsenate would still work as an insecticide, and it would be cheaper than using a permethrin-based chemical. So I had to pull a study team together to look at it. So I first called in Saiful Islam. He's a sociologist who'd done a lot of the outbreak investigations that I mentioned where we had seen pesticide overuse. Sarkar Parvez is a field epidemiologist, and I knew he could help with organizing a field team, collecting samples, putting questionnaires together. And Rubana Rakib is a laboratory scientist who has great standards and runs a really good lab, and I knew that she could analyze the specimens. Stanford Woods Institute for the Environment put out a call for proposals that they wanted to see interdisciplinary collaboration. So I talked to Roz Naylor, who's a food economist, to Scott Fendorf, who's a soil scientist, and to Pascaline Dupas, who's a developmental economist, to see if I could get them interested around this question. And I got real rocket fuel when a PhD student, Jenna Forsythe, said she was also interested in the project. So what we wanted to know was we wanted to evaluate the severity of lead poisoning in rural Bangladesh and to identify the pathways of exposure. One of the hard things about doing research in global health is that getting money for those research questions is not easy. And you have to persuade people that the knowledge you're going to generate, the question you want to ask, is worthwhile. I'm thrilled that Creighton is making funds available for some innovative ideas for global health. So we appealed to the Woods Institute and were very pleased when we were given support by the selection committee to move this forward. Though I have to say at the same time, we were still reaching out to thought leaders and still trying to understand this process better. And one of the people we reached out to was John Duxbury, who's a professor of soil science and international agriculture at Cornell and has been working in Bangladesh for 15 years. So when he heard about our hypothesis, he responded, this is a direct quote from his email, "I would be very surprised if there is environmental lead contamination in rural Bangladesh. I don't know any reason why lead-containing pesticides would be used in Bangladesh. The problem of lead contamination of food is more associated with soil and dust contamination than with uptake into plants. Translocation to grain is very low." So, kind of took a deep breath and said, well, I'm kind of glad he wasn't on the selection committee for the EVPs. But also made me wonder a little bit about, were we on the wrong track? And we thought a lot about it and said, well, maybe he's right. Maybe there isn't any lead in the agricultural system. But on the other hand, it's very hard to explain why in Chandpur and in Dinajpur, very two separate regions, why there would be lead in folks. So we thought we would go ahead. I already had another big trial in the field looking in 4 different districts doing a water sanitation hygiene intervention. So we leveraged that population. We were enrolling 6,000 pregnant women. We added collection of a lead-free tube of blood from mothers at baseline and added a question asking mothers if they grew all or nearly all of their rice from their own agricultural fields. And we randomly selected 430 of them. Took those blood samples and sent them to my colleague, Rubana Rakib, in the lab. She called me on the phone and said, "This is really troubling. I have run all the controls. I don't understand why these people have lead. Why should people in central Bangladesh have lead?" So it turned out that John Duxbury's prediction wasn't right, at least in that 31% of these moms had greater than 5 micrograms per deciliter of lead in their blood. And you can see 10 of them having greater than 15. So there was, again, this curious situation. We had replicated the findings from Chandpur and Dinajpur, suggesting that this is a widespread problem in rural Bangladesh. We also, since we're epidemiologists, we like to not only look at things as persons, we also like to look in place. We saw that there seemed to be even some geographical clustering around where some of the lead was most commonly elevated. So this turns out to be a standard circumstance to be in epidemiology. We have an outcome, lead intoxication, which we've now confirmed. They saw it in Dinajpur, they saw it in Chandpur, we see it across 4 districts. We now know that many people in rural Bangladesh have intoxication with lead. The question is, why? How? How is lead getting into these folks who doesn't appear have any of the traditionally explicated pathways? So we had a study question, which exposures are more common among people with high blood lead levels compared with low levels? So we want to compare, so we did a case control study. So our cases were these 82 women who had the highest blood lead levels, that had greater than 7 micrograms per deciliter, and we compared them to the women who had no more than 1 micrograms per deciliter. So what we were asking is, what's different about these women compared to these women? So how to think about that? Well, anthropology really helps. So Saiful Islam, he's trained both as a sociologist and in anthropological methods. So one of the things we need to do is to go and spend hours with a bunch of those women who have high lead levels and look to see, wait a minute, is there a battery recycling factory here we didn't know about? Are there other things going on? Looking at all of the possibilities and talking to them about what they do. Exhaustive reading of the literature, anything we could find on exposures that might generate lead in low-income countries. And after taking all of this information in, we then actually generated a 29-page questionnaire about all these possible exposures. Everything from distance from the road, is your roof made of tin? Do you have tin in your roof, your walls? What are your cooking pots made of? Are there any glazes, any paints anywhere? What cosmetics do you use? What kind of jewelry do you wear? Is there any type of recycled materials or batteries? What kind of food do you consume? Do you grind your wheat? Are there agrochemicals? We even collected some soil. So we collected lots of information, and then we then collected that, and then we could compare the exposures between cases with high lead and controls with low lead. So what did we find? This is pretty typical. We asked people, did you paint any surface in the last year? And sure enough, 12% of cases reported, yep, we painted a surface in the last year. But so did 22% of controls. So, yeah, cases had some exposure to paint, but actually less than controls. Similarly, we asked about using coal. Coal is a particular cosmetic that sometimes can be contaminated with lead. Sure enough, 9% of cases reported they sometimes use coal, but similar to controls. We asked about consuming spice from a local mill because one of the companies in Bangladesh was selling turmeric that was contaminated with lead chromate. So yeah, they sometimes did that, but no difference from cases and controls. We asked about trisodium phosphate fertilizer, similar in cases and controls. Preparing pesticides in the house, not a recommended activity, pretty common among cases, not a big difference in controls. So, and we actually then went through the 29-page questionnaire. We had lots of ideas about potential stress. What could it be? What could it? And we just kept scratching them off. Because if they're no more common among controls than in cases, then they don't explain this difference. But there were a few things that were different. Cases were 2.5 times more likely to report sometimes consuming food that had been in a can. They were 3.3 times more likely to report grinding last year's rice. They were 3.2 times more likely to report using a particular product, product X, as a pesticide on rice. They were 2.9 times more likely to report using any herbicide, and 2.6 times more likely to report using product Y. So what conclusions then do we draw from these data? Well, as is often the case in global health, it's not simple. There's no single silver bullet there. On the other hand, it looks like there are several exposures that are different in cases and controls, and that we ought to think about this. Now, I also mentioned we collected some samples. We collected some samples from agricultural fields. And again, these looked a lot like the earlier data from Chittagong University. And yes, there was lead there, but at pretty low levels. On the other hand, when we took rice samples from the households, we found very high levels of lead in rice, very high levels, 0.65 parts per million when the EPA action level is 0.1. In fact, if we look at how much pregnant women were getting, it was 22 times the provisional maximum tolerating dose. So really high levels of lead in rice, but curiously, similar levels in cases and controls. So one thing is, wait a minute, you're researchers, isn't it time to go publish in a journal? Well, we'd already presented to the government of Bangladesh, and we'd convened press conferences. We've been widely covered in the Bangladesh press. So the knowledge was out there in terms of the local community. And when we talked to our scientific colleagues, they were pretty skeptical. They were very skeptical of the results. They came back to John Duxbury's point. Wait a minute, rice does not accumulate lead. This shouldn't happen. And there was a lot of skepticism over our use of X-ray fluorescence to detect lead. So we looked again at our methods. We went back and said, wait a minute, how does X-ray fluorescence compare to other methods? We would look and said, no, this really looks okay. And a common complaint against epidemiological data is, well, that's fine, Steve, but you had a 29-page questionnaire. You get a few things that come up. Of course, you're going to find some things. Are we really going to believe this? So I was asked to give a talk at Stanford, and I knew that in the audience was going to be Paul Fire, a Nobel laureate, and I'm getting ready to pull all this together and make this case about how we're trying to understand lead. And then the night before, my PhD student, Jenna Forsyth, sends me an email. Steve, I spoke with a student who analyzed the Cambodia rice data. She said that she analyzed the data using inductively coupled plasma optical emission spectrometry and X-ray fluorescence, and that the two methods did not yield similar results. The X-ray fluorescence data are not valid. This supports the trend I've seen. Last week, I adjusted and analyzed 10 rice samples and saw very little lead, whereas when we did these with X-ray fluorescence, the range in lead concentration was 0.3 to 1.4. So what's the lesson you draw from this? Number one, be very careful about engaging students. This is the kind of trouble they cause. So I've gone on the record. I'm publicly saying there's lead in the rice. We've spoken to the government of Bangladesh. We've had press conferences. Your abstract says it. And a smart medical student and a smart PhD student tells me, Steve, I think we're wrong. I think we're wrong. So, and there's an element here that John Duxbury, there was part of what he said that was right as well. So what do we do? Well, in one sense, this actually made a little bit of sense, too. There was no difference in the exposure between cases and controls. So maybe we should get back and look at those. Was reporting eating food that had been in a can. And so we did in-depth interviews on can owners. It turns out people weren't like going and buying Dinty Moore stew and then having this at home. Rather, they were buying oil in these cans, or there would be cans that had been used originally to store chemicals, and then they would use that to store puffed rice or other food. So we did in-depth anthropological interviews with can owners, what they stored in them, where they purchased. We collected 28 of those cans, and Jenna dissolved sections of the cans in sulfuric acid and tested for lead using an appropriate technique for metals. So what did we find? Well, 5 of the 6 large cans had lead concentrations of 107,000 to 394,000 parts per million of lead. That is, that the lead near the seam was 10 to 30% by weight of lead. And you just see how much higher this is than any of the other numbers I've shown you. It's consistent with typical lead solder, and these were mainly used to store puffed rice, but had previously stored cooking oil. None of the smaller cans had appreciable lead. So we then took those cans and put them on the linear accelerator at Stanford to actually try to visualize what it looks like. And what you can see, the red there is iron and the green is lead. And right at the seams, you can see that the lead is right there, so that we could confirm not only that we have an epidemiological link between canned food and lead, but that we can actually see lead in the cans, that lead is present in high concentration in some cans used to store food in rural Bangladesh. So the second thing we looked at was rice grinding. We visited 15 mills, and we collected rice and metal tools that were used. And we learned that repairs to the grinding stones happened only rarely, and that the grinding stones were roughened with a metal tool. And if you look at the lead concentrations here, you can see that unhusked rice had a fair amount of lead, but not very much at all in husked rice. So the unhusked rice higher, is that because maybe of soil contamination, maybe agrochemicals, maybe some physiology, but really little evidence in the tested mills that grinding introduced lead. And the metal tools also had little lead. So we had a strong signal from the epidemiologic study, but initial physical pathway assessment was unpersuasive. And so we're planning additional sampling in selected mills. Our third pathway we looked at was agrochemicals. So we collected some of that pesticide X, and because it was a solid, we had to use X-ray fluorescence, and that was felt to be appropriate on that sample. And we saw 32.1 parts per million of lead with 10 parts per million of arsenic, which, if you do the molar ratio, we would expect pure lead arsenate to be 1.33, and the specimen was 1.11, and so felt to be consistent with a high concentration of lead arsenate. In addition, there had been a study done in Sri Lanka taking 26 pesticide samples. This pesticide was also made in the same country in India and imported. And the mean pesticide concentration in those 26 pesticide samples in Sri Lanka was 40.6 micrograms per gram. So we now have collected 333 additional samples collected for markets throughout the area over the 12 months, and those lead analyses are underway. So it turns out that there are actually 4 isotopes of lead. That is, they have different atomic weights. 3 of these types result from independent decay chains of uranium and thorium. And so the ratio of the isotopes from lead, if you reflect the geological history of this sample. So it means that lead that comes from different places will actually have different mixtures of the lead isotopes. And so our plan is to compare the lead isotope ratio from the blood in women to the lead that we find in our physical pathways, and to help us identify which of these pathways are likely to be most important. So as we think about what we've learned about lead exposure in Bangladesh, is first, it's not simple. There's not one thing. This is no longer get the lead out of the gasoline. We believe there are multiple pathways. We have a strong signal on storing storing food in cans that contain lead. We have a signal from agrochemicals, and we have some other issues that we're still working on. Prevention, because there are multiple pathways, will require multiple strategies. But the better knowledge, the new knowledge we generate before we did this study, there's not a widespread appreciation that lead is a problem in these communities, and there are over 100 million people living in these communities in rural Bangladesh, and I suspect we could go across all of South Asia and find similar problems. Understanding the pathway that it's coming through actually gives us some opportunities for intervention, and we've gotten some support to look at some strategies for encouraging alternative ways to store foods. We know that weak states have limited power to enforce regulations. So it's actually pretty easy for us to get pesticides banned. That would be very, we can get the Department of Environment to ban those pesticides, and we'll work on that. But the only laws that are consistently enforced in Bangladesh are the laws of physics. So it's really important. People, oh, wait a minute, let's put our research into policy. Well, okay, I think it's fine to have research into policy, but the real question is, can you change practices so that exposures meaningfully change? So in conclusion, lead is a particularly dangerous toxin. There's widespread lead intoxication among residents of Bangladesh. Better understanding the pathways of contamination will support intervention. And I also wanted to underscore, this is an interdisciplinary gathering. It's not all about epidemiology, it's not all about medicine, but thinking about both the epidemiological evidence and the physical investigation of sources helps us to improve our scientific understanding. Also, if we want to make headway on substantive problems, we really need prolonged engagement. The idea of what they call at CDC parachute epidemiology. Oh, there's a crisis. Oh, let's go in and work real hard for a few months, and then we'll tell them what to do, write the paper, and go away. That's not a good model for addressing these problems, which not only require a deep understanding of the problem, but then iterative efforts to reduce that burden. So thank you very much. Questions? It seems to affect some of the T helper lymphocyte functions, and so kids who have exposure to lead also end up with some immunologic dysfunction and increased risk of infectious disease, particularly in settings like Bangladesh, where there is a rich environment of pathogens. Yes.
Wonderful presentation. Good, like who done it. Did you ever do like a back of the envelope calculation looking at say simply multiplying out, if the sort of ratios, so in the 40 to 30 women, if that say to generalize the entire population of sort of women in all the agricultural areas in Bangladesh, then the probability of it having effect. You do a background calculation of percentage of IQ point shaved off
Yeah.
each year. Do nothing about it. If you did it,
Yeah, no, it's a great question, and it's just shocking to me that that we get put off by saying, yeah, well, what's a few IQ points? You're an economist, so you understand that a few IQ points changes the whole distribution of the whole country. There are enormous changes in productivity in making this a healthier country for the future. If you look at the removal of lead from gasoline in the US, it is ranked as the most cost-effective public health intervention ever. It's something like, it's just outrageous. It's something like $10,000 return for every $1 invested. So we are trying to frame this around, our goal is to frame this around an attributable risk calculation. So attributable risk is a little more difficult to calculate from a case control design compared to a cohort design. But because we think the lead isotopes might help us a little bit, we're very interested in this. And part of this narrative that we're trying to talk to policymakers and to funders and to thinking about what's the next step is precisely this. I mean, it may not be as dramatic as seeing death immediately in front of you, but these are huge effects. Yes?
While cooking in Bangladesh, they use this kerosene stoves and at times lighter. Have you studied them and studied correlation between them and the level?
Yeah, we have done a lot of work on indoor air issues. I don't think we had kerosene stoves in the case control study. I would have to actually look at it. I mean, kerosene itself, we wouldn't expect to give off lead. We did look a lot at what the materials were, that the cooking pots were that would be heated and potentially that might, but we did not, I don't think we looked specifically at kerosene stoves.
Because in that part of the world, kerosene oil would be an expensive item to carry in a home, so they would actually make sure that it's there in safe, maybe in the kitchen.
Yeah. In these communities, there's very little kerosene used. I mean, almost all of that is agricultural biomass waste that they use. So if we did this in urban, there are some urban sites where it would be live, but not in these communities. Very, very little kerosene. Yeah.
Who makes the pesticide? Is it cheap to make? Where's the stuff that's full of
Yeah, that's a great issue, and it's what I see one of the core political economy issues here, is that it is cheap. It's really cheap to make lead arsenate. In fact, if we went and took those same blood samples and tested them for DDT, I'm sure we would find DDT as well. So there's all kinds of illegal pesticides, and what is said on the label has nothing to do with what's actually in there. And so people use pesticides really empirically. Do I put it out there? Do insects die? Yes, got to be working. What are the incentives for pesticide manufacturers? Well, if I lower my costs, I can sell more pesticide. So who would know? And they're able to do this because, I mean, it's a camouflage. Like the government of India says, it's okay that the use of DDT in India is illegal but you can make it here and sell it somewhere else. Part of the reason that we're interested in the isotope analysis is that we actually may be able to get very specific and pinpoint. And if we could find a chemical signature, we might even be able to trace it to a particular manufacturer. That even though it goes through so many rebrandings that to be imported and then they change it and write it in Bengali, we might be able to trace back. I think that the new technology is something that can be very helpful and sometimes disruptive in global health. One of the problems with heavy metal contamination in general is that it's so silent you can't see it. At least in the US, it's pretty cheap now. You can go out and you can test to find out whether you have lead in paint. But that's actually a much higher level than we would expect. But we are continuing to explore. This is the kind of thing like the Stanford School of Engineering guys get really excited about. Can we get a really inexpensive way to be able to measure lead at much lower concentration? So you could imagine, for example, we've got economists working on the team, that you could figure out a way so that big purchasers of rice or big purchasers of pesticides or of food products would pay less for something that's confirmed to be lead-free. And can we change those incentives? But I think that part of this is going to be some naming and shaming. And part of that will actually probably come, too, from replication of the work in other countries. Yes? Yeah. Yeah, so most of the pesticides that are used in low-income countries come from China and India. And neither of the, in both of those, we have concerns with quality control. We got pretty interested in thinking about Kenya and other places in sub-Saharan Africa, but Roz Naylor, our food economist, said, focus first in Asia because it's so much more rice dominant and there's so much more pesticide use per capita. So I think, I mean, I lived for 5 years in Pakistan. I lived for 8 years in Bangladesh. I have little doubt that I would have very similar findings in Pakistan and across much of India. I think whether this would be an issue in Africa is an open question, but a question that I think should be looked at. I mean, there has been some work done in Cameroon about lead contamination of pots and pans that raises considerable concern. Yes. Oh. So her one question was to say, do you know you only have 1 more minute? So apparently I didn't know. Well, thank you very much.